All right, welcome to Chapter 1, Introduction to Emergency Services. So in order to give you an idea of how EMS works, we're going to start at the beginning. In 1790, the French physicians created what we now know as battlefield medicine. They were the first ones to go out of the hospitals, out of the areas that have been set up to take care of patients, and actually onto the battlefield, similar to how we go directly to the scene. In 1861, it was brought to America during the Civil War. That time period, Clara Barton established what we now know as the American Red Cross. And she and another group of volunteers would go out into the field. They would pull people regardless of what size they were and do immediate interventions and then bring them back to care for them. In the early 1900s is when we saw our first non-military ambulances ran. These were being run by undertakers. So what you would see is the same vehicles that would bring someone who is deceased to a funeral home would also bring patients to local doctor's offices, local clinics, things like that. In 1914, during World War I, we saw our first volunteer ambulance corps. So instead of the undertakers, these were people who were volunteering specifically to take care of patients. And then in 1928, we had our very first independent volunteer rescue squad, and it just so happened to be in this state. So this is going to be the first one in the entire country, and it was Roanoke Life Saving and First Aid Crew in Roanoke, Virginia, so a local area. They are still functioning today, and they're still volunteer. In 1950, during the Korean War, we saw medical teams, and for the first time, we saw specialized trauma centers. So what that means is the hospital went under specialized education and specialized equipment to specifically be able to handle different kinds of trauma. In 1966, the Department of Transportation was tasked to develop an EMS system. At that time, it was determined that what we needed was somebody to fix the problem of people dying on the highways, and therefore we fell underneath the Department of Transportation, which we still do to this day. In 1970, the National Registry of Emergency Medical Technicians was established. And then in 1973, federal regulation for EMS came out called the National Emergency Medical Services Act, which we'll talk about. So, Department of Transportation. Again, in 1966, they became in charge with us, and they had to develop these EMS standards that said what we should be, what EMS was. And what they did too is assist each of the states to upgrade the quality of their pre-hospital emergency care to make sure that what the care you received in Virginia was the same care that you'd receive in Wyoming, in Colorado, etc. Our EMT class that we're teaching today is based off of the models developed by the Department of Transportation, as we still fall under them today. So, National Registry. In 1970, it was established to give us standards. It was a professional standard to make sure that an EMT was an EMT was an EMT. And it became the certifying body for our first responders, EMTs, AMTs, and paramedics. And they're who you will eventually test through. So all states in the United States except for New York, New Jersey, West Virginia, North Carolina, Illinois, and Montana use them for their testing standard. So Virginia, probably about 10 years ago, went to National Registry simply because maintaining and certifying a test that keeps up with current standards is difficult and expensive. So we go underneath National Registry. And for those of you that are under the age of 18 and will be when you test, you won't be certified in National Registry, as they don't certify anyone under 18. But you will take their test and you'll get certified as a Virginia provider. And then when you turn 18, you'll be able to apply for a National Registry certification. The National Emergency Medical Services Act came out in 1973, and this became the cornerstone of federal effort to implement EMS countrywide. What it did is make sure there was a standard, so that whether you called for help in, rural Virginia or in populated New York City, you got the same standard of care. This is also where our 911 systems came from, so that you could figure out what number to call no matter where you were. So they created what's called the EMS standards. So the very first one they created was regulation and policy. They said that each state has to have somebody in charge of EMS. There has to be written legislation in place that says that EMS has to be there, what they're going to do, what policies, regulations, procedures we're going to follow. And then if we're going to do all that, there has to be money set aside so that we can, in fact, do it. The next thing they did is resource management. So what that means is there has to be some kind of coordination so that all patients have equal access to basic emergency care. This is how we make sure that there are always somebody on the other end of the 911s. There's always at least an ambulance coming. Next was human resources and training. They said, all right, so we've got resources and regulations. Now somebody's got to be on the ambulance. And so they took the time to create this standard that would make sure that all transporting ambulances have at minimum an EMT, the class that we're taking now. The next one they came up with was transportation. So it required safe, reliable ambulance transportation, making sure that units were inspected by the state entities, making sure they had a minimum set of equipment, making sure they had a minimum safety requirements, and the same with helicopter and airplane transportation, and also allowed those two vehicles to be utilized as a type of ambulance. Then they said, all right, we've got all these things to transport and these providers to transport the patients with. We now need to figure out and make sure they get to the right location. So they required that all seriously ill or injured patients be delivered in a timely manner to an appropriate facility. And they made sure that there were facilities available. Things like the freestanding ER in Gretna, Halifax Regional, Danville Regional, Lynchburg, different levels of facilities and opportunities for patient care. But we made sure they were there and present and would take ambulances. The next thing that came along is communication. So we have the places to go, the facilities to transport them to, the equipment to transport them on, and the providers. Now we need to make sure that one, there's a unified number for people to get to an ambulance, and that said ambulance is able to talk to other providers, to the hospital, and that the hospitals can talk to each other. And then next they said, our job is public information and education. We have this unique perspective by being able to go inside people's houses, see their cars, see how they live, to be able to educate. We can educate about things like trip hazards. We can educate about resources available in your community, the ability to make sure that they can access the system, what our role is. In the grand scheme of things, EMS is still a fairly new profession in the healthcare world, and people don't always understand what we're actually here for. Then they said, we're going to have all this stuff, all this education, all these patient care, all of this, and it needs to be oversaw by someone. So they put a medical director position in. And that means that in order to teach this class, in order to operate on an ambulance, in order to do any of the skills that I've been trained to do and that you'll be trained to do, you have to have a medical director who signs off on you and is accountable for what you do. So for our program here, it's Dr. Kayla Long. She is in charge of the VOTEC program. And she is the one who ultimately makes sure that the information that I'm teaching and the information that y'all are utilizing and the clinical skills that you're utilizing when you go out into the field are correct. And then next they decided that we had to have some kind of trauma system. And what this meant was that when people were getting hurt on the highway and were having these, massive traumatic injuries, that they had somewhere to go. So we had to have more than one trauma center. We had to have a triage process, transfer guidelines, somewhere for them to go to recover after they get released from the hospital. Of course, data had to be collected so the government knew who was, killing themselves where, doing what on a car. And then there had to be mandatory autopsies, again, to collect that data. So they were able to say that, this seatbelt or that airbag or whatever it was caused damage. Ultimately, this is where seatbelts, more than just lap belts and airbags, came from. And then we said there has to be some kind of evaluation, because in order to know that things are right, we have to know what we're holding them against. And so they came up with a program for evaluating and improving the effectiveness of the system. So quality improvement and quality assurance. What that looks like in the state of Virginia is that each agency is responsible for QMing, or quality management, and looking at reports when they're done. And they're responsible for making sure their times stay up to date. They're responsible for making sure their response times are appropriate, their on-scene times are appropriate, that appropriate patient care is being delivered. All that falls under the evaluation standard. So those are all of our standards. Next, we go on to the levels of training. So there's 4 different levels of training that we're going to talk about. This is at a registry level. There's an additional one in the state of Virginia. I'm just going to mention here, it's called EMTI, or an intermediate. It is a Virginia-only thing. It used to be a national registry level. They went ahead and transitioned it out a few years ago, around 2014, 2015, but the state of Virginia chose to keep it. So the first certification level that we're going to talk about is EMR, or Emergency Medical Responder. This used to be called First Responder, and it is designed to be exactly what it sounds like, the first person on scene. The whole concept behind this is activation of EMS, making sure we've got the right resources coming, and providing immediate care related to airway, breathing, and circulation. This level is the only one that is not actually qualified to transport the patient in the back of the ambulance by themselves. Now, they can ride on an ambulance, they can drive the ambulance, but the person in the back providing care has to be at least an EMT. Which leads to our next level, Emergency Medical Technician, which is the class that y'all are in. When you complete this class, you'll be eligible to test for this level. You may hear it called EMTB or Basic, but right now, under National Registry Standards, it's considered Emergency Medical Technician, or EMT. Again, this is the minimal level of training to be able to transport a patient. You have some basic level of medical and trauma care, and you are going to be allowed to administer 10 medications, which we'll learn about later on. Your level above this is Advanced Medical Technicians, or AEMTs. They were previously called Enhanced Providers, Shock Trauma, Cardiac Technicians. They've been quite a few things over the years here in the state of Virginia. They provide that same BLS care that y'all are going to be learning. In addition to that, they learn some advanced things. The advanced care that they learn are things like administration of IV fluids, and then some additional medications on top of the 10 that y'all are already able to do. So after Advanced Emergency Medical Technician is where that intermediate would fit in that I talked about. But again, that's only in the state of Virginia. It's not for National Registry, so we're not going to lecture on it because you won't be tested on it. I just want to make you aware because you probably will be riding with some intermediates. You also have a couple that'll probably be coming in and helping us teach. So the next one for National Registry, level-wise, is going to be paramedic. That's what I am, and then Miss Hilton, who's also going to be coming in, is also a paramedic. So this used to be called EMTP, now it's just paramedic. They have all the skills and assessments of both the EMT and the AEMT, and then some other things such as intubation, just an advanced airway technique, some cardiac medications, cardiac monitoring, ALS assessments. This is a 2-year degree. Now, it didn't used to be a 2-year degree, but it is now a 2-year degree. It's a National Registry certification. So you spend the same amount of time in school as a nurse would with an associate's degree. And this is the highest level of pre-hospital care that you can get. We are going to have at some point over the course, we're going to have the instructor for Patrick Henry Community College who teaches this program, who actually taught both Miss Hilton and myself, come in here and talk to you a little bit about the program and some of that, in case that's one of the options you're looking at when you get out of high school, in the end of when you guys graduate. So, now that we know the 4 roles, we're going to talk about roles and responsibilities of the EMT. So the first one is going to be personal safety. So when we talk scenarios, when we talk everyday functioning, when we talk driving, it is always going to be personal safety. If you're not safe, you can't take care of other people. And then in that same kind of concept, the very next thing is going to be the safety of your crew, then your patient, then your bystanders. And it goes in that order. So you have to be safe, then your crew has to be safe, then your patient has to be safe, and then bystanders. This is where things like staging until PD gets on scene for calls like gunshot wounds or overdoses. This is where making sure you can read the patients in the scene. That's where all of this kind of comes in, making sure you can communicate with your partner. Bystanders can be really dangerous. It's kind of all of that. And then right here, so this particular picture is of an ambulance that was involved in a rollover accident. This was a personal safety issue, so they were on the way to a call that they never got to because they rolled the ambulance. So it's your role, whether you're driving or in the passenger seat as the AIC, to make sure that you're safely traveling to scenes. Next is going to be working with other safety professionals. It's going to be very rare for you to end up on a call where someone else is not involved, especially if you end up running in the city or in other big cities. And basically, the nice way to put this is you've got to play nice with others. Just like we learned in preschool where we have to share and play nice in the sandbox, we have to play nice with PD, fire, again, special operations, ALS, helicopter crews, nurses, hospitals, all of that. We got to play nice with everybody. Another big, important, to me, the absolute most important thing we do is going to be patient assessment. All right? So patient assessment is our absolute most important skill. It is what will allow you to not only know what's going on with your patient, but be able to give an accurate and proper turnover report, be able to do accurate interventions, be able to call for appropriate resources. It's something we're going to spend a lot of time focusing on this class. We started early and we reinforce it because assessment is one of the most important skills, and your assessment skills will follow you whether you choose to stay in EMS or go into nursing or any kind of medical field. Patient assessment is going to be one of your number one skills. Your next role and responsibility is going to be patient care. So now that we've made sure the scene is safe, we've played nice with others that came, we've assessed our patient, we now have to take care of them. And again, part of why assessment is so important is because everything we do for the patient is going to be based on that assessment that you do. Based on the things that you found, whether it's measurable findings such as blood pressure, heart rate, things like that, or it's kind of more signs and symptoms or things that we see or the patient says. All of that is going to go into what we actually do to care for the patient. Following that, lifting and moving. So you're going to do a lot of lifting and moving in this job. You're going to have a lot of patients that are in positions that are just undescribable and unintelligible in how they even manage to get in that position. You're going to have patients you need to carry downstairs or carry upstairs, backboard and move, help off the ground, move from beds to stretchers and move stretchers to ambulances. And so making sure that we do that in a safe manner, not only for our patient, but for us and our partner, so that nobody's hurting their back or their knee or anything that may alter their career or their lives. And then next is transport. So not only is this safe transport, so making sure that the ambulance is driven appropriately, safely, at a correct speed, it's also transport to appropriate locations. As we go through class, we'll talk about things like heart attacks and strokes and major traumas, and how those kind of high acuity, high level patients need to go to facilities that are equipped to handle them, if at all possible. So in most situations, those patients aren't going to be appropriate to go to Gretna. They're going to be appropriate to go to like Lynchburg as a level 2 trauma center, or Duke or Roanoke as level 1s, cath lab centers, things like that. And we'll talk about that as we get into each of those chapters. And then transfer of care. So we've done all this stuff for our patient. We've hopefully done a really good quality assessment. We provided good quality patient care. We've made sure we got them there safely. We've taken them to the appropriate location. And now we're going to go ahead and hand them over to the nurse. So when we do that, we're going to make sure we give a good quality turnover report. The nurse and those at the receiving facility weren't on scene. They weren't able to see what we saw They weren't able to maybe necessarily get the same story from the family or from whoever that we got. And so we need to make sure that what we were told, what we saw, what we found, what we did is appropriately turned over. And then your final role and responsibility as an EMT here is going to be patient advocacy. So I've spoken a couple times on how we see a different viewpoint than the hospital does. We see the homes without electricity. We see the patients who are unable to care for themselves. We see the unsafe location that they're living in, or the possible abuse or neglect in the household. And your job is to stand up for your patient. So that's where patient advocacy comes in. So in your warm-up activity, we talked a little bit about, or in your warm-up activity tomorrow, we're going to talk a little bit about traits of a good EMT. But we're going to go over them here too. So physical traits. You're going to have to be able to lift and carry up to about 125 pounds with a partner. And we'll talk about that when we do that practical day on kind of some of the tips and techniques to be able to help you lift a little bit more and to do so safely. You have to be coordinated and be able to move patients, operate stair chairs, move cots, things like that. Good eyesight. If you have contacts, glasses, whatever, you need to make sure you're wearing them. And then be aware of any color vision problems. Something that says you can't do this job without it. I know a few paramedics who have some visions with red, or have some problems with red and green. But you need to know, because it may affect how you assess a patient, how you move something, change something. Because if I tell you to look for, signs of cyanosis on a patient, and that's what makes them turn kind of bluish purple, and that's a color you're unable to see, it's not going to work. So we need to figure out ways around it. We need to be able to give and receive written and oral directions. So we need to be able to communicate with our partners, bystanders, patients, the hospital, etc. And then you also need to be able to write and read, because you're going to have to be able to read protocols and write down narratives and documentation, things like that. Personality-wise, you have to be pleasant. Not saying 24/7, but a lot of the times we end up seeing people on their worst day. For them, what they've called for is truly an emergency, has them upset, they're in need of assistance, so we need to be pleasant, sincere, and cooperative, resourceful. You're on a box, oftentimes with just you and your partner, and there are going to be times where what you hope is going to work or what your original plan is doesn't work. So you need to be resourceful. You need to be a self-starter. There isn't usually, depending on the environment that you work in, there's not usually somebody, showing up to tell you exactly what to do every day. There's a generalized, hey, check your truck, do this, do that. But otherwise, it's on you to stay motivated to make sure your stuff gets done. Emotionally stable, able to lead, have good moral character, be respectful to others no matter their walk of life, be in control of your personal habits. So I put this one in here, and it specifically says alcohol, but any kind of addiction that you may have problems with, we have to be in control of in this field. We obviously can't go to work. We can't show up on an ambulance having drank or smoked or done drugs or anything like that. Be able to control your conversation. I promise you there will be patients and bystanders and family members that are going to test your patience. There are going to be situations where you are going to want to be able to tell people things that are not professional and things that we should not say. You need to be able to control that. You need to have the ability to actively listen to your patients, so not just to have what they heard be said, but be able to process and listen and ask questions. You need to be non-judgmental and fair. There are going to be situations that are just baffling, things that you simply do not understand. You may see over the years, and you have to make sure that we do not come across as judgmental. We are there to provide care for the patients. And then you need to make sure that you keep your ambulance neat and clean, so that when we're putting patients in there, we're able to quickly put hands on things that we need to be able to utilize. So, we've gone over the traits and the roles and responsibilities. So what do you do once you get certified? Well, once you're certified, it's going to be your responsibility to remain up to date on knowledge. I got my EMT quite a few years ago. while I was in high school myself, and have since then made sure that I keep up to date on protocol updates, make sure that I stay up to date on current practices, studies, standards, etc. There's options like a full refresher class. The Naval Area Life Training Center does those occasionally. There's also options that are online or in person. There's options that like come into a classroom, an EMT class, and get continuing education that way. Or depending on the agency that you run at, they may give you some additional continuing education while you do monthly training. So now that we've gone over kind of what makes a good EMT, what to do after you get certified, things like that, let's talk about what your role is once you are certified. So your first role is going to be quality improvement. And this is going to be continuous self-review of how you function and what you've been doing. Everybody in that organization has a role. So you need to make sure that your documentation is written appropriately, done in an appropriate time and done in a quality manner. Become involved in the quality process if given the opportunity. It's a good way to learn. Obtain feedback from patients, hospital staff if given, and listen to it. Maintain your equipment and make sure that you keep up with your education. You are going to have a medical director. It's your role to kind of know who they are, who's responsible for you, because they are going to be ultimately responsible for any patient care that you give. They're going to oversee your training, whether that be directly or just by overseeing the program itself. Develop treatment protocols, the things that we're going to be allowed to function and do in the field. Issue standing orders, which may be something on top of those protocols, something extra. And then provide actual online medical direction if they're the one working or available. Research. So there's two different ways that research affects what we do in EMS. One is going to focus on improving overall patient outcome, and then one is through the evidence-based techniques. Unfortunately, just because of how dynamic what we do is, we don't know when we're going to see patients. We don't know what kind of patients we're going to see. We don't even know how many are going to be there when we get there. It's difficult to research EMS. So there's going to be peer-reviewed research in medical journals and articles in EMS magazines. So you have a responsibility to kind of know which one is more tried and true, which one has more backing to it. So a peer-reviewed research in a medical journal is something that has been reviewed, it's been sourced, they have made sure that the material that has been covered and the conclusions that have been made are backed up. Articles in EMS magazines, while usually very thorough in information and good information to have, are usually not originally researched and they're not peer-reviewed, which means they are the opinion of the author, and that means they're not always right. And they may not always utilize the most current up-to-date data, and their conclusions may not have been reached by a scientific method. Now, sometimes they may be, but make sure that when you are looking at research, when you're trying to stay up to date with things, that you're looking at the sources, the data, collection points, the time frame it was done over, the number of patients, etc. And then finally, public health. So I know I've stressed it a few times, but I'll bring it up again. As you can see in the pictures here, the top there with the little bumpers and the rocking chair and the rug, all of those are trip hazards. And we probably can, I know I can name a dozen houses I've been in that I've seen exactly this. A little dog and a walker are a great way to ask for someone to trip. Those little rugs on hardwood floors slide around. And rocking chairs are not very stable to be getting out of if they're using a walker. So doing things like, hey, can I pick this rug up for you? Let me explain why, it's really dangerous. Or, it might be, I know rocking chairs are great, but it might be a really good idea to get one that's a little more solid. Or to be able to get a chair like a recliner that can rock, but can be locked. Our bottom picture here shows a provider inserting a car seat. Now, this is an additional class on top of EMT, but it's one that may be something that y'all are interested in at some point in your career. But you can go and get certified to be able to make sure the car seats are placed properly, which is a great public health and public outreach program. And then the other one is going to be vaccines. Some of your role in EMS may involve administering vaccines at some point or assisting in a vaccine clinic. And that's just something that's part of our public health. And so again, that injury prevention and geriatrics and for the youth, public vaccination, and then of course disease surveillance. So when I say disease surveillance, it more means that we see things that other people don't see. We are significantly more likely to notice that somebody has missed, not missed, but that somebody's gotten sick, and that maybe it's a whole household or everybody. We've picked up 5 patients and taken them to 5 different hospitals, but every one of them has the same story in regards to having eaten at a certain restaurant the night before, or been at a certain, large-scale event the day before, whatever it may be. We may notice outbreaks before the hospitals do, just by the nature of what we do. Alright, so that concludes chapter 1. If you guys want to complete your guided notes, again, those are for you to complete. They're not to turn in for a grade. They're just to kind of help you get an idea of what's important. And we'll take this information and those guided notes and any reading that you've done, and we'll apply it tomorrow to some in-class stuff, as well as kind of a recap. Remember, again, if there's anything that you have questions on during this, anything you didn't understand, you're more than welcome to email, but please bring the discussion points to class as well, so that we can talk about them, because there may be others that had the same questions.